So what we need to do is that when we plan surgeries, a thorough examination is must, which includes overall health, the diabetic status, the ischemic heart disease, the hypertension. This has to be fairly well controlled before going for all this surgery, because the beauty of surgery lies in control of his risk factors, which includes all the tests which we do before the surgery, but more importantly, which we have introduced in our hospital, where we do a pre-op echocardiography, which will make us wiser irrespective of the age group. A good look at the venous Doppler, where we can sometimes catch up with the DVTs before surgery and possibly treat them if they are significant, and then go ahead with the planned replacements. Third is that we also rule out COPDs and bronchial asthmas before going for the surgery, as we know that post-operatively we can have drowsiness, and sometimes it can delay the sort of development of recovery from any surgeries. We also like to rule out any history of allergy, because sometimes giving post-operative analgesics can also give rise to kidney problems, sometimes exacerbate the respiratory problems. Last but not least, we should think of patients who are on long-term treatment with steroids, taking non-allopathic treatments, because that has also helped us in getting some idea of the recovery and post-op hypotension, which is very commonly seen with people who are taking non-allopathic treatment or treatment for arthritis or on steroids, how to taper them off before going for this major surgery. And of course, education to the patients, which makes us wiser that the recovery is going to be slow, and you have to be good on mobilization, which is a very crux part of early recovery, and possibly helps us in overall grooming the patient for a healthy life and pain-free life. Pain management, as Dr. Diwan has already told us, that works wonderful, and in fact, a post-op period, decreased pain management is useful in mobility, increasing the respiratory compliance, and also possibly reducing the stress on the heart. Thromboprophylaxis we all have been aware of, and everyone uses, in fact, immediately post-operatively, and that has reduced significant pulmonary embolism or even sometimes coronary problems in most of the patients. And if there is a contraindication that there is a bleeding disorders, we should rule off before the surgery. A quick PTINR, or sometimes the platelets are low, then we should confine ourselves to leg compression devices, which can be useful in preventing long-term embolic phenomena. Wound care is must, and early mobilization makes us wiser. We like to optimize the cardiac condition. Suppose someone has got a problem of ischemic heart disease, LV function is poor. We need to stabilize them a couple of weeks, give diuretics, see that the patient does not go into post-op congestive cardiac failure, make them negative a little bit before the surgery, and avoid intra-op too much of fluids, which we usually speak to the anesthetists and try to manage. And that has reduced us from getting prolonged stays in our intensive care. Also, of course, we are aware of the glycemic controls, pre-op and post-op very important, and which most of us follow. There's no hurry in operating a patient with sugar of 400 1 day prior to surgery. We can always wait, stabilize, and do it after a week or so if there's no contraindication, until this is an emergency of operating a septic arthritis. Pulmonary optimization, as if there's a patient of osteomatic, and sometimes a patient needs to be on nebulization for a long time. Good spirometry before the surgeries for 2 days prior makes us wiser, and post-operatively continue that so that we have a less chance of putting him on long-term oxygenation and sometimes BiPAP support. This point which we would like to highlight is that we did a study where we found that temperature control intra-op has found to have a significant reduction in the local risk of infection at the surgical site. Now, what do you mean by that? A normal temperature which we should maintain between 36 to 38 centigrade has been an acceptable and shown to prove that it has reduced significant infection in most of the surgical patients. There's other risks, like the patient should be on quick low molecular heparin if the kidney functions are normal. If they are on the higher side, then we can put them the conventional heparin, either per kg body weight or depending upon the patient's compliance. And third is stockings, which we have already discussed, which will make us wiser in early ambulation. Other thing which we found, complications which include local, in the very rare percent, less than 1%, infections, especially uncontrolled diabetics. So look at the wound daily. See that if there is a discharge, the surgeon usually sees the wound and makes us aware that they should be on some staphylococcal covering antibiotics for a few days. And also, if the wound is increasing, then we need to look for the cause and decrease blood supply at that particular area by doing an arterial Dopplers. We had a tough time with sometimes managing the patients with ischemic heart disease with getting atrial fibrillations. So a pre-op cardiac assessment in these patients and rate control before starting the surgery is very essential, even if it's an atrial fibrillation with irregular heart rate. and sometimes we are prone for getting myocardial infarction. So we do not stop echospinning clopidogrel too long. We then put them on low amount of heparin before surgery, and this has known to minimize the risk of myocardial ischemia and heart failure. Patients with most of the COPDs need to have a good blood gases. So post-operatively, if you do them, I think things do very well. And the challenging things could be cardiac patients with compromised function, and challenging patients could be a valvular heart disease like aortic stenosis, which we do get frequently and is often diagnosed late in the age group. So good 2D echo makes us wiser. So preventing them from getting a volume overload is very important. So the checkpoints could be the blood parameters, the echocardiography, look for venous thrombosis, any previous history of any drugs which are long-term like the steroids that the patient is on, you can reduce them. And if they are on immunosuppression for something like a connective tissue disorders, you can minimize them before going for all these surgeries. And I think the failure rate or even the infection rate or complications is very less in this beautiful surgery. And that is why I think most of the aircrafts where I travel are now copying this art of knee joint replacement concept, where I think they are using for the first class and business class the same thing. So it's such a beauty in this orthopedic side. I think the airlines are doing the same thing. So I think let's avoid them by, I think rather than calling just plain knee joint replacement, it's worth calling them a business class knee joint replacement or a hip joint replacement. Thank you very much for this patient hearing.